Thank you so much, Kira. Welcome to the webinar today, everyone. Vascular Dementia, an important supporting actor in the story of dementia. In this webinar series, the Administration for Community Living's National Alzheimer's and Dementia Resource Center has partnered with the American Society on Aging. We're pleased to have all of you in attendance today. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Good morning, everyone. I just wanted to thank all of you for taking the time to attend this webinar on such a very important topic. The importance of it is demonstrated by the strong turnout we've shown for this webinar. Dr. Knopman, thank you so much for sharing your expertise with us. We very much appreciate it, and we look forward to learning a lot in the next hour. So back to you, Sari.
Thank you so much, Erin. So as you've heard for today's webinar, we'll be hearing from Dr. Dave Knopman. Dr. Knopman is a clinical neurologist and professor of neurology at the Mayo Clinic. He's involved in research related to cognitive disorders such as mild cognitive impairment and dementia, with a specific interest in the very early stages of Alzheimer's disease, in cognitive impairment due to stroke, and in cognitive impairment due to frontotemporal degeneration. We thank you for being here today, Dr. Knopman, and I will turn it over to you for your presentation.
Great, thanks, Sari. Well, thank you for inviting me to give this presentation, and I'm really pleased to do this. I'll get my first slide up here. So I'll try to explain my title and what the meaning of vascular dementia is over the course of the next 35 minutes or so to you. So first of all, the term vascular dementia is meant to mean a condition where there's a disorder of thinking, memory, and behavior that I'm going to refer to as a cognitive behavioral disorder that is caused by cerebrovascular disease, that's caused by disease of the blood vessels of the brain, or disease in the blood vessels of the brain. Strokes are obviously the most common and layperson known consequence of disease of blood vessels of the brain, and we're going to try to integrate that idea of strokes and vascular dementia over the course of this talk. Now, from this point forward, more or less, I'm going to say that I prefer to use the term vascular cognitive impairment because, as we'll talk about in a second, dementia has a somewhat more narrow meaning, whereas vascular cognitive impairment has a broader meaning. So this is what I'm referring to. Across the spectrum of cognitive function of thinking and memory in a population. Obviously, most people are in the realm at the far left-hand side as you're looking at the slide who are cognitively normal. But and this slide isn't meant to say that it's inevitable that people move from cognitively normal to mild cognitive impairment to dementia, but rather the purpose of this slide is to highlight the idea or the notion that what we call cognitively normal sometimes can be a little fuzzy in distinguishing what actually represents mild cognitive impairment, and similarly the boundary between mild cognitive impairment and dementia can be a little bit fuzzy. So just in terms of terminology, mild cognitive impairment is a term that's widely used in the world of cognitive disorders in the elderly that indicates that a person has cognitive difficulties that are obvious or evident, but they don't really interfere with daily life. In other words, they're mild. Whereas the term dementia specifically means that there is cognitive impairment of a sufficient magnitude to interfere with daily life. That's the key definition of dementia, and so the key difference between mild cognitive impairment and dementia is whether or not daily life is interfered with. And because this whole realm of symptomatic cognitive impairment is really what's important to us, using the word dementia is just a little bit too restrictive, and that's why I in the field, it's not just me, use the terminology here, vascular cognitive impairment. Now, the cognitive impairment that goes along with cerebrovascular disease is unfortunately not specific for cerebrovascular disease compared to Alzheimer's disease or Lewy body disease or any other specific brain disease. In other words, any range of any type of cognitive dysfunction can occur with cerebrovascular disease as the underlying cause, so that people can be slow, as this slide talks about. They just are slow in mental processing. They can have memory problems. They can have problems with understanding spatial relationships, or they can have problems with getting lost, i.e. having geographic orientation problems. They can certainly have language problems, word finding problems, or motor speech problems. So the symptomatology of cerebrovascular disease is really quite diverse, and seeing one particular pattern is not diagnostic of cerebrovascular disease or diagnostic of not cerebrovascular disease. It's also important to mention that in addition to cognition, by which I mean memory, language, mental agility, spatial abilities, behavior is also disturbed in people who have cerebrovascular disease. In particular, apathy, lack of interest in activities, lack of motivation is a fairly common symptom, but some people can be, as we'll talk about at the end, we talk about management, they can be experience agitation, they can experience hallucinations, any type of behavior. But if there was one particular behavior, especially early in the disease, that characterized cerebrovascular causes of cognitive impairment, it would be apathy. Now, we have to put cerebrovascular disease in the bigger context here. The bigger context is that Alzheimer's disease, that is a particular pattern of what we call neuritic plaques and neurofibrillary tangles, is the most common brain disease that causes late life cognitive impairment. The key point for cerebrovascular disease is that it often overlaps with Alzheimer's disease. And another important point of thinking about vascular cognitive impairment and why vascular dementia is not a great term is that the term vascular dementia seems to suggest that that's the only problem, and it rarely is. People who have cerebrovascular disease almost always, and if they're elderly, almost also have Alzheimer's disease. This slide also indicates that the disorder Lewy body disease and frontotemporal dementias are also important elements of later life cognitive impairment. And although this slide doesn't show it, there is actual overlap between Lewy body and cerebrovascular disease as well. So the key point here, the take-home message, is that cerebrovascular disease sometimes occurs by itself, but it usually occurs in conjunction with other diseases, especially Alzheimer's. Now, in terms of diagnosis, 30 or 40 years ago, it was thought that vascular dementia, again using the older term, was the result and could be diagnosed by the presence of a history of strokes, of clear-cut physician-diagnosed strokes, And the bottom line is that it turned out that that wasn't quite the case. It was also then thought when MR scanning and became available, well, maybe vascular dementia is a combination of a history of strokes and a history of strokes, or what I'm going to call infarcts on the scan. You can see the strokes on the scan. Well, that led to a definition that's still one that is widely used in some circles of vascular dementia as a history of stroke at some point in the past, brain imaging evidence of infarction, which is just our fancy word for stroke, and on the neurologic exam, there are things like hemiparesis, weakness of one side of the body or another, or hemianopia, such as loss of vision in one visual field. It turns out that this definition is not a very good one. It is very insensitive. In other words, this definition that's on this slide doesn't pick up a lot of cerebrovascular disease, and that's why we've replaced it with calling a more realistic model. We think about vascular disease contributing to cognitive impairment. We can't always prove it's the cause, but contributing to try to make the point that cerebrovascular disease can be variable, it can be incremental, and even if it's not the cause, it's still important. So here are some of the key features we need to, and key principles. So cerebrovascular disease is age-related. I'll show some slides about this, but unfortunately, overt, clinically obvious cerebrovascular disease and clinically silent cerebrovascular disease increases with advancing age. As we've talked about before, it's heterogeneous in its clinical presentations, and sometimes there is evidence on imaging or by history that turns out not to be relevant, and sometimes it is relevant. So it's complex, and this also points to the fact that we're still missing some pieces here that require further research into understanding what is the most important part of cerebrovascular disease that does affect thinking and memory. Okay, now to switch gears slightly, cerebrovascular disease doesn't occur in a vacuum. As I'm sure all of you know, stroke is a common consequence of a variety of what are called vascular risk factors, in particular the four that I mentioned here: diabetes, hypertension, cigarette smoking, and elevated lipids, hyperlipidemia. And we'll talk about these more in a second. There are some heart diseases that are also relevant to the brain as well. In particular, the heart rhythm disturbance, atrial fibrillation, often is associated with blood clots forming in the left atrium of the heart, and those blood clots can break off and go to the brain and cause serious consequences. Even acute heart attacks can lead to blood clots inside the heart that break off and go to the brain. Prosthetic heart valves would be another example. There are some less common ones, but those are the most important ones. Now, these vascular risk factors, especially diabetes, hypertension, hyperlipidemia, cigarette smoking, and their attendant problems with obesity and or lack of exercise, don't start in late life. In this slide, I depicted the vascular risk factors beginning at age 40, but that's not even correct either. The fact is that the tendency for diabetes or hypertension probably begins in the 20s and 30s, depending upon people's activity levels, depending upon whether they started to smoke cigarettes when they were younger, depending upon weight control and things like that. So it turns out that midlife vascular risk factors are really very important for understanding the later life consequences of cerebrovascular disease and the consequences on the brain for cognition and behavior. Stroke tends to be a later life experience, but that's really something that itself is also caused by the rise in midlife of the risk factors like diabetes and hypertension or continuing to smoke. So just a little bit about diabetes and hypertension because they're the most important ones. Diabetes is a common disorder. It affects as many as 20%, 25% of elderly individuals. Hypertension is also very common. Midlife hyperlipidemia also seems to be more important for reasons that aren't well understood compared to late life hyperlipidemia. And there's nothing good to say about cigarette smoking, of course. It does cause strokes, and I'll talk about that more in a second. So all of these risk factors are associated with a later risk for dementia, a later risk for cognitive impairment, a later risk for stroke, and they also have changes. They also affect the brain in ways that we can see with MR scans. For example, people who have long-standing diabetes tend to have slightly more shrunken, atrophic brains than people who don't. People with hypertension have more disease in the white matter of the brain, which I'll show in a couple minutes, than people who don't have hypertension. And both diabetes and hypertension are associated with tiny strokes that we call lacunar strokes. So there is a clear link between having these risk factors, especially in midlife, and again, especially diabetes and hypertension, with causing changes in the brain and causing changes in thinking and memory and behavior. This may all sound somewhat grim, but there's some recent research that is actually very encouraging. I'm showing here the title of a paper that was published in the Journal of the American Medical Association 2 months ago on a large trial that was conducted in the U.S. with over 4,000 people, in which the participants were assigned to either blood pressure control at a systolic blood pressure of 140 or to a more aggressive approach of a systolic of 120. And it turned out that in the trial, the people who were randomized to the more aggressive blood pressure control had a lower risk of the combined outcome of mild cognitive impairment and dementia. This is very exciting. There's still more work to do. It's not a huge effect, but it was real. And it's interesting, the population that was in this study were over age 50, and it wasn't just the older people who benefited or just the younger. It was both groups. And just to point out on this slide that what this shows is the cumulative rate or incidence of dementia. In the orange is the intensive treatment, and the standard treatment is in blue. And you can see that after about 6 years, the lines are diverging such that those who got the standard treatment were at higher risk for subsequent dementia. The take-home message from this trial is that attention to blood pressure, presumably younger as well, but at least in midlife, has beneficial effects on reducing the risk of future dementia. And hopefully this will work its way into clinical practice and have consequences down the road in terms of reduced burden of dementia in our population. Now, let's just dig a little bit deeper in thinking about the implications of stroke. It turns out that if somebody has a stroke that lands them in the hospital and they have obvious weakness and they might need rehab for a few days thereafter or weeks thereafter, these people turn out to be at very high risk for developing dementia. And I mean the word in the sense that I'm using it specifically, substantial cognitive impairment within or by 12 months after the stroke. So having a stroke is a risk factor for a strong predictor of dementia in the future. But how about the situation where, how about the situation where somebody has a stroke and they might have had weakness for a few days, but then they recover, they don't need to go to rehab. It turns out that those people also have an increased risk of dementia later in life, but the risk is much lower than those who had the higher deficits, and that risk that the stroke stood for plays out over years or maybe even decades. And the thought is that the stroke is like the tip of an iceberg of brain blood vessel disease, cerebrovascular disease, that's going to manifest itself later. What I'm going to turn to now is to just show some examples of brain imaging. And this is really important because the availability of MR scanning widely in almost all communities in the U.S. at least gives us a much more accurate and detailed view of the burden of cerebrovascular disease that any particular individual might have. So I'm going to show some examples on the next couple slides of three different types of vascular imaging abnormalities. The first is ischemic stroke. So ischemic strokes are where there's a blood vessel blockage and the brain regions downstream of that blockage die. That can be due to large blood vessel blockages that are due to atherosclerosis, such as in the carotid artery in the neck or in the vertebral or basilar arteries at the base of the brain, or more commonly, actually, for our purposes in thinking about cognitive impairment, the small blood vessels of the brain can be affected, the arterioles, and so we call that arteriolosclerosis. And those lead to these type of abnormalities that I'll show in a second called lacunar strokes, lacunar infarcts, or even infarcts that we still can't see with brain imaging in living people. Now, sometimes the strokes can be hemorrhagic. In other words, they can have blood associated with them. The mechanisms are the same. It just depends whether the blood vessel wall leaks blood into the brain or not. There is one other variation on that, and it turns out that in Alzheimer's disease, one of the core proteins of Alzheimer's disease called beta amyloid also can get into the blood vessel, the small blood vessels of the brain, and sometimes they leak as well. So that's a little bit different than the type of blood vessel disease that's due to diabetes, hypertension, and typical atherosclerosis, but it's important nonetheless. Third, it turns out that there are changes in the white matter of the brain in people, especially as we talked about, who have hypertension or have other vascular diseases, and those can be demonstrated as well. So let me show an example of a case of a man who came to my clinic a number of years ago who had a history of memory problems, according to him and his exam and his family. He had no history of stroke by their history. But when we did an MR scan, we saw multiple small strokes that I've highlighted here with the arrows. These black areas. So actually, let me just back up a second. This is a coronal section of the brain. That is, it's taken of an up and down view. The ears are over on the side, top of the head here. The inner cavities of the ventricle, called the ventricles, are in the middle of the brain, and the spots that the yellow arrows are pointing to represent small strokes. We call those lacunar infarctions, but small stroke, small infarct, same thing. And this man had multiple ones of these. And it turns out that with studies of individuals like that who then are followed in research and come and have a brain autopsy when they die, this burden of stroke is probably enough to account for this man's cognitive impairment, whether or not he had Alzheimer's disease or anything else. So this is one common pattern of how cerebrovascular disease manifests itself in the brain. And again, I emphasize that this occurred in a silent, quote-unquote, manner. This man didn't have typical strokes. These things, these lesions in the brain that we're showing appeared silently or covertly. So this slide shows some of the other examples. I showed the top left-hand man just a second ago. The middle top slide shows this black area here at my arrow. I should have had an arrow on the slide as well. That's a microhemorrhage that's due to what's called amyloid angiopathy, the abnormal accumulation of beta amyloid in the blood vessels in people who are at risk for Alzheimer's disease. Usually these things by themselves might not have any consequences, but one, it indicates there could be underlying Alzheimer's disease, and two, if there's a lot of them, it probably is important. The third pattern are the white matter hyperintensities that I was talking about a second ago. This is a good example in the top right where there's extensive changes in the white matter that probably, almost certainly, in a situation like the scan I'm showing, has consequences for speed of thinking, probably for memory, and is an example of a cerebrovascular lesion that occurs on a gradual basis. Then going down to the bottom, on the bottom left is an example of a large stroke in the left frontal lobe. There's actually a stroke deep in the brain as well, a little further back. Here's a stroke in the middle of the bottom set of pictures that affects the part of the brain that's involved in memory called the medial temporal lobe. It's a fairly large stroke. And then finally, on the lower right, is this white dot. And it turns out that the region where that white dot is present is an area of the brain called the medial dorsal thalamus. And it's exquisitely involved. It's strongly involved in memory. So these are all examples of cerebrovascular lesions that can be seen on imaging that are important for cognitive functioning. And any of these can occur, and they can occur in combination. The point of this slide is just a fairly simple demonstration to show that on the left, white matter hyperintensities, and on the right, brain infarcts, increase with advancing age. Interestingly, in this study, which is from the Mayo Clinic study of aging, there was more white matter disease in women than men. That might be important to understand differences between men and women and dementia risk. But the key point on the left-hand slide is that the burden of the white matter disease, the probability of having abnormal white matter disease increases pretty dramatically with age, from less than 10% to nearly half of the population by age 90. And similarly, the subcortical infarcts infarcts increased with advancing age as well. It's interesting that the so-called cortical infarcts don't increase that much with age, and the reasons for that aren't entirely clear. So to talk now, move on to talking about management. I don't have very good news for people who have existing vascular cognitive impairment. There aren't any approved therapeutics for people with vascular dementia or vascular cognitive impairment. There's some work that's beginning to occur more intensely now, but it's been a difficult area for research. It turns out that the medications that are approved for Alzheimer's disease, such as donepezil, rivastigmine, galantamine, or memantine, really have no value in people who have substantial cerebrovascular disease that's thought to be the cause of their cognitive impairment. The point is that it's easy to say here, it's harder to live with, is that prevention is something that is within our grasp of reducing the burden of cerebrovascular disease and its effects on the brain beginning in midlife. And that is an important point to keep in mind from a public health point of view, more than a day-to-day clinical practice point of view. In terms of managing patients with vascular cognitive impairment, in many ways, the actual day-to-day management of behaviors and problems and need for assistance really doesn't differ very much from people with Alzheimer dementia versus vascular cognitive impairment or Lewy body disease. You do, the things that are specific, of course, would be to continue to treat vascular risk factors such as diabetes, hypertension, try to support the greatest independence possible for any patient, be mindful of safety issues, whether it's walking and balance problems or driving, which needs to be addressed, or firearms in the home, or other issues in the home such as steps or things like that, just in the environment. Walking and balance problems do need careful attention. Often in older people, these problems aren't due just to one thing, but they're due to multiple things. Certainly cerebrovascular disease and vascular cognitive impairment is associated with a greater likelihood of having problems with walking, which could have been due to a stroke that caused some mild one-sided weakness, or it could have been due to associated peripheral vascular disease, which also is a fellow traveler, you might say, with cerebrovascular disease. But older people are also ones who've had hip and knee surgeries or who have peripheral neuropathy, and one has to clinician has to be able to look at the big picture and assume that problems with walking and balance aren't due to just one thing, but many things. Managing behavioral changes, again, is pretty generic, very important. Treating depression if it's present, treating agitation or trying to manage or minimize agitation when it's present is also very important. I think it's beyond the scope of this talk to talk about managing things like physically aggressive behaviors or verbally aggressive behaviors, but just to make a few points about it, using the less medication is always the best route, and if strategies can be put in place that minimize the disruptive behaviors, that is far better than using medication. For example, if a patient becomes physically aggressive while they when they're bathed, don't bathe them every day, bathe them every other day, and sometimes in situations like that, certain caregivers are just better and have a better touch than others, and those people should be used. So I want to also emphasize the importance of these things, which actually come from the American Heart Association. So I stole them, which they welcome, of course. Addressing these 7 really important things, beginning in midlife, exercise, which, by the way, are all interrelated. You're likely to avoid obesity if you exercise and have a reasonable diet. Avoiding and treating hypertension or avoiding and treating diabetes also can have benefits in terms of enabling exercise. If a person isn't overweight, they're less likely to have diabetes and hypertension. Nothing more needs to be said other than the exclamation mark after don't smoke. And then treating hyperlipidemia. All of these things seem to have an impact in later life on reducing the burden of cerebrovascular disease and therefore reducing the burden of vascular cognitive impairment in the population. So to finish up and summarize, I've made a couple of key points here. The first is that cerebrovascular disease is common. We talked about the frequency of hypertension and diabetes in the population, and that translates to cerebrovascular disease itself being a common contributor to cognitive impairment in late life, even if it's not the sole player, even if it's not the marquee player, it's playing a role even when it's accompanying Alzheimer's disease. Next. The clinical diagnosis of vascular cognitive impairment can be challenging. The diagnosis is based on learning whether or not a person has a history of stroke, and if they do, that is certainly a feature in favor of thinking about vascular disease as a contributor. But if somebody doesn't have a history of stroke, performing brain imaging to see if they have any of those various brain imaging abnormalities that I showed, which if they were present in large numbers would increase the likelihood that cerebrovascular disease was relevant. So performing an MR scan, preferably CT scan, is okay if an MR is not available or is contraindicated if there's a pacemaker or some other reason. But it is the case that the MR gives much more detailed information. Thinking about it as a public health problem more as is very important, because prevention begins in midlife, and I've already made that point several times. I don't need to belabor it. So I will stop here and we'll be able to take some questions. Thank you very much.
Great. Thank you so much, Dr. Knopman. That was fantastic. We have lots of questions coming in. So feel free to keep entering your questions into the question and answer chat feature of the webinar platform. One of the questions that came in has to do with prevalence of vascular dementia compared to Lewy body dementia and frontotemporal degeneration. Are you able to comment on that? People are saying, you know, there's different prevalence estimates, and they want to understand what the most up-to-date thinking is.
Yes. So I should have emphasized that on this slide. Can people still see my slides?
Yes, they can.
Okay, so I went back to this slide, and this slide was an approximate attempt to convey the relative frequencies. The numbers, you can't get hung up on the 10th of a decimal point here, but what would be a good round estimate is that Alzheimer's disease contributes to about 60 to 80% of dementia, and cerebrovascular disease and Lewy body are roughly equal, and somewhere contribute between each about 10 to 15% in a typical U.S. population. And those are really the big three in the elderly. It turns out that the frontotemporal dementias become rather uncommon after age 65 or 70. If we were talking, though, about a population under age 65, this picture would look completely different. There'd be very little cerebrovascular disease, very little Lewy body disease, and actually frontotemporal dementia would be almost as large as Alzheimer's. But one of the things that I didn't include in my slides is the point that dementia increases with advancing age. And under age 65, it is quite infrequent, whereas after age 85, perhaps as many as 4 in 10 people have dementia. So I hope I'm answering the question okay. It really depends on the age you're talking about. If we're just talking about a generally older population, the slide I'm showing is accurate, or is a good cartoon depiction of it.
Great, thank you. Someone else is asking about, in particular with vascular cognitive impairment, are there any differences in prevalence by race or ethnicity that are significant that people should know about?
That's a good question. Well, cerebrovascular disease is more common in populations where midlife health is not as good as it could be. And that would include, unfortunately, African Americans who don't always have access to high quality care throughout their lives, and also to rural whites. Vascular disease is very common in a belt across the southeastern United States that's called the stroke belt. That's not just African Americans, it's whites, and it probably reflects an increased prevalence of incompletely treated hypertension, incompletely treated or untreated diabetes, and cigarette smoking. So there are differences. Whether it's all environmental, in other words, healthcare, access to healthcare, or whether it's genetic, isn't known at this point.
Great, thank you. A few people have asked if you, on slides 10 and 11, you reference midlife and young adulthood, and later on you reference elderly. Do you have any ages that you use as specific ages, or is it more of a range?
No, it's just a range, and there's no line in the sand between what's young and what's midlife. I think the line in the sand between midlife and elderly is 2 years older than me. That's a joke. In other words, that it doesn't. Some people are younger than their chronologic age and some not. Generally speaking, 65 is used at the cutoff for older, but that applies to group thinking, not to an individual. So middle age, roughly 40 to 65, but there's nothing magic about those numbers.
Okay, great. An interesting question came in. I don't know if there's any research yet on this, but someone was asking, you talked about, don't smoke, that's a risk factor is easily controlled. Has there been any research on how vaping might affect the risk for stroke and later cognitive impairment?
Oh, no, none at all. That's a recent bad habit, and so I can't answer that.
Okay. Great. And another person was asking about if you could talk a little bit about the difference between lacunar infarct and TIA, so they can understand a little bit better about how each contributes.
Good. Yeah, that's a good question, and I didn't. So let's, we have to step back a second. I don't have a slide for that. And let's just talk about definitions. And let's just talk about, first, clinical events. A TIA is called a transient ischemic attack. And that is a spell where a person has neurologic symptoms that's thought to be due to a blood vessel blockage. A stroke, or we call technically a completed stroke, is where there are symptoms due to a blood vessel blockage that last for more than 24 hours. So the transient ischemic attacks have symptoms that last for less than 24 hours. Strokes, the symptoms last for more than 24 hours. Okay? That's TIA versus completed stroke. Now, let's talk about just the brain changes, the imaging changes. People can have a small stroke, and lacunar strokes are meant to, technically they're less than a centimeter in their diameter. That's a lacunar, I'm going to use the word infarct, a lacunar infarct. A lacunar infarct sometimes can cause a TIA and sometimes can cause a completed stroke. So I hope that the listener can understand the difference between the symptomatic manifestations and then the actual brain lesions. So a lacunar stroke is one that's less than a centimeter in diameter, and it can cause either no symptoms or just cause transient symptoms, a TIA, or a completed stroke. It just depends where it is and other things. A lacunar infarct is something that we would differentiate from what's called a large territorial stroke, where there's a much broader area of brain that is infarcted. And so lacunar infarcts represent tiny areas of ischemic damage to the brain. Large territorial infarcts represent large areas of ischemic destruction of the brain. Hope that's clear.
Great, thank you so much. One question that came in was asking if you have any additional tips that you can offer in managing behavioral issues that are presented in patients who have vascular cognitive impairment. This came up a few times about other ways that you might be able to manage the symptoms, in particular any behavioral issues.
Right. Well, it's a really important question and a topic in itself, really. And it's not specific for vascular cognitive impairment. It all depends on the person, the caregivers, and the circumstance. And each person is different, and each circumstance is different. I gave an example of say, physical aggression when people are being bathed. But there might be an example of somebody who gets physically aggressive when they try to walk out of a door of their care facility and the staff has to restrain them. Well, to me, the solution in that kind of situation isn't to use medications, but to have that person live in a place where the doors are secured so that nobody has to be involved in restraining that individual. They just can't get out. They can bang on the door, but they can't physically exit and get into trouble. And you don't want to get into a battle with the patient over care issues, whether it's wanting to leave the facility or bathe or something like that. And it turns out, by the way, that research has shown that most physically aggressive behavior is precipitated by things that the caregivers do. And I don't mean that as a criticism of caregivers. It's just that physically aggressive behavior is rarely spontaneous on the part of a patient with dementia. It's usually triggered by some action of people getting into their space. And so thinking about that and thinking about solutions without medication is really the way to start. I'm sorry I can't go into more detail on that, but I hope that helps a little.
Great, thank you. Let's see. Someone mentioned, you mentioned that medications are not helpful for vascular cognitive impairment. Now, what if someone has Alzheimer's, type dementia, and vascular cognitive impairment. Are the medications for Alzheimer's disease then useful?
Well,
can they be useful?
They can. The research doesn't show that. None of these drugs achieved approval for vascular dementia. And in the studies that were done, this was quite a while ago, almost undoubtedly people had both cerebrovascular disease and Alzheimer's, but they were done in a time when the clinical diagnoses left something to be desired. I think that what you can say is that when it seems like a person has both cerebrovascular disease and Alzheimer's disease as a cause of their dementia, it wouldn't be unreasonable to use those medications, but I think expectations have to be properly set to not overpromise. And unfortunately, even in people with Alzheimer's disease, it's getting a little beyond my topic here, donepezil, rivastigmine, and galantamine and memantine have rather modest benefits, unfortunately.
Okay, great, thank you. Let's see. Someone was asking for a little clarification on the clinical study you mentioned on blood pressure treatment.
Yes.
They were wondering if the intensive treatment involved medications, or were there differences in behavioral treatment?
Oh, no, it was all medications, sorry. Okay. Yeah, it was all medication, right. And they can go online. I'm sure it's publicly available. It's called the Sprint Mind Study, S-P-R-I-N-T, new word mind. And if you just Google on that, you probably can get the Journal of the American Medical Association original article to look at.
Great, thank you. Someone was asking about how young, what is the youngest that you would say you would see cerebrovascular disease and vascular cognitive impairment?
That's a good question. I think what we need to do is break that question into two. First, when would be the typical age? And that would be in gradually beginning in the 50s, but especially in the 70s and 80s. The reason it has to be broken into two is that some younger people, unfortunately, who might have type 1 diabetes and who have vascular complications, or who have valvular heart disease, or who have some other disease of blood vessels, can have strokes at any age that can cause cognitive impairment, unfortunately. But those are far, far less common than the kind that's due to blood vessel aging.
Great, thank you. A few questions came in asking about alcohol use and if there's been any research done on a link between chronic alcohol use or heavy alcohol use and vascular cognitive impairment.
Okay, that's a great question. It's actually more difficult to answer. Generally speaking, the studies that have been done in large populations find that low to moderate alcohol use is actually protective of cardiovascular and cerebrovascular disease. But this is, and I'm not an expert in this area, but I think one or at most 2 drinks a night of whatever a typical portion is. Anything more than that actually is somewhat more difficult to study, because people who are alcoholic tend not to participate as volunteers in observational studies over years, and I don't think we really understand the full range of risk of of excess use of alcohol. Unfortunately, excess use of alcohol doesn't occur in isolation. It occurs in people who are more likely to smoke, and separating out the smoking from the alcohol can be difficult. It's also, excess alcohol use is also much more likely to occur in people who otherwise have poor health practices. They don't go to the doc, they don't treat their hypertension, they don't know that they're hypertensive, they and et cetera. So it's a difficult question to answer, and I think that for obvious reasons, heavy alcohol use is bad for a myriad of other reasons, and it's hard to believe that it could be helpful to the brain. So I think it should be avoided in any case.
Great, thank you. We have time for one or two more questions. There was a question that came in early on asking about any resources you know of where you can see videos that are focused on vascular dementia or scenes that might depict the kind of behavior, verbal or nonverbal, that you might see in a patient that has vascular cognitive impairment.
No, I'm afraid I don't know anything like that at all. Hope perhaps somebody else does. I would emphasize, though, as I said a couple times, that the behavior changes that occur in people with vascular cognitive impairment are really very similar in the broad sense of the word to the kinds of behavior changes that occur with many of the other dementias. Some are unique, but some aren't. So I don't think that other than the very particular circumstances of one particular patient, that talking about behavior changes in vascular dementia would be any different than talking about talking about behavior changes in dementia in general.
Okay, great. Thank you. I think we're going to stop there for today with the questions and with the webinar portion. I want to thank you so much for your great presentation. This has been fantastic. A lot of great knowledge has been shared, and you can see our participants were very engaged. There were lots and lots of questions. So thank you again for your participation, Dr. Knopman. Thank you to everyone who joined us today.